So this is a talk that I've actually done several times over the last year. It could go anywhere from 10 minutes was the fastest time I've done this, but it could go on for an hour, just lots to cover. But I trimmed this one down to try and keep it to the pertinence. So essentially, I think it's a very important question is our patients that have been treated with dual antiplatelet therapy, when they come back at 1 year, at that time, should we actually continue or should we stop? And we're going to talk about this both in the context of ACS as well as in patients after stents. These are my disclosures. So the objective today is to discuss the potential advantages and disadvantages of either a shortened strategy or prolonged strategy of dual antiplatelet therapy after stenting. In particular, I'm going to review two of the latest trials. One is the DAPT study. The other is the Pegasus. And at the end, I'm actually going to cover a special presentation that was just done at AHA to talk about how to possibly apply some of the post-hoc analysis from DAPT into clinical practice. And then finally, to review how these can impact in terms of how we manage our patients. So just to give you a brief review, the current P2Y12 inhibitors that we use after ACS and after stenting are these: clopidogrel, the old standard; Prasugrel, which is also a phenylpyridine, so it also requires a biotransformation in the liver; and Brilinta or ticagrelor, which is the new kid on the block. The difference being that it's not a phenylpyridine, and it actually is a direct inhibitor of the P2Y12 receptor, thus potentially giving faster onset in terms of both of these drugs actually give a faster onset compared to clopidogrel and also a much higher bioactivity. So this, unfortunately, is what all interventionalists dread. This is a 44-year-old patient that comes in with a STEMI, had a remote stent in the LAD, and unfortunately had a stent thrombosis and blocked the stent. So this was actually done by a Japanese group where they actually put an angioscope in, and these little metallic spots here are exposed stent struts. And this has been shown, especially with older generation stents, to be persistent even at up to a year or longer. And so patients are potentially at risk for blocking their stents, and that was the impetus in terms of these long-term dual antiplatelet studies. So these, unfortunately, we see all the time when we do cases of stent thrombosis, we pull out these big, long clots. The other extreme, and this is a real patient of mine, is a 34-year-old here that came in originally with an anterior, uneventful stenting procedure, discharged home on aspirin and ticagrelor. And unfortunately, a week afterward, comes to the general and had a hemoglobin of 80. Upper GI scope at that time showed gastritis, transfused 3 units, and the decision was to keep the patient on ticagrelor because it saves lives. A week after discharge, readmitted with a melena, had an acute endoscopy, could not get a source of bleeding, and they decided urgently to embolize a branch of his gastric artery with interventional radiology. 4 days later, he actually has a syncopal episode on ward at the general, recurrent GI bleed, transfused 9 units in total, and this time they actually cauterized an ulcer. So that gives you a flavor in terms of the divergence between the bleeding and the potential ischemic complications and why this is an important topic. And I think there's increased concerns around increased dual antiplatelet therapy, partly on a patient front, and we're doing the two extremes. We've got the young patient I showed you. We've also the 9-year-olds that we unfortunately also see downstairs. Potential side effects of these drugs, and of course, cost for our patients. There are physicians' considerations as well in terms of we're concerned about bleeding complications. Our patients, sometimes when we start them on drugs, end up having a surgical lesion that gets discovered when their malignancy becomes apparent, and at that point we have to make decisions. And also the types of stent makes a big difference as well. So before I go through the majority of my talk, I just want to quickly tell you what the CCS guidelines say right now. And right now the recommendation is that clopidogrel or any of the other 2 antiplatelet drugs for at least 12 months in addition to aspirin for patients after BMS or DES for non-ST elevation ACS. The other part, however, is that for those patients that have received a second-generation drug-eluting stent who are unable to take a prolonged dual antiplatelet therapy, there is some preliminary evidence that a shorter duration might be okay, and depending on the stent, it might be 1 month or 3 months, which I'll quickly review in a few slides. So the first little bit is there any evidence to actually shorten the duration of therapy? So this was actually done by a group that took all the stents that were in, so cobalt chromium stents, so second generation everolimus eluting stents, and compared it to either bare metal stents or old generation, first generation drug-eluting stent. And what you clearly see is, in terms of the stent thrombosis risk, all of them clearly show benefit of using a new generation stent versus an old generation stent. And this other study here shows the same thing. When you look at paclitaxel and sirolimus, our first generation stent, compared to the everolimus eluting stent, the event rates are much, much lower at up to 4 years. So this is actually an interesting analysis that was actually done through the studies of one of the drug companies, one of the stent companies. So this is actually their cobalt chromium stent. And basically what they did was they looked at patients that had interruption of the dual antiplatelet therapy at 1 month versus those that did not. And what you clearly see is that at the 1 month, if someone had stopped or interrupted their dual antiplatelet therapy within that first month, the event rate is almost 3% versus 0.6% in patients that did not have any interruption of the dual antiplatelet therapy. They then excluded these patients and did a separate analysis for those patients that had interruption after that first 1 month. And what you see here is that there is actually 0 events, so next to no events in terms of patients then had interrupted dual antiplatelet therapy, suggesting that in the era of these new drug-eluting stents, that the event rates, especially after 1 month, is much lower than the old generation stents. So with all of that in mind, several groups, both in Europe and in Asia, have actually done short-term versus long-term dual antiplatelet therapy in a randomized fashion. But most of these were done at either very short term, so at either 3 months or 6 months versus 12 months. And this is one of those studies called Optimize, where you see that there is no difference between the two. The difficulty, though, is that these are against 12 months, not longer than 12 months, which I'm going to show you in the 2 largest studies in terms of long-term dual antiplatelet therapy. The other thing, of course, is that these are lower risk patients, so the majority are not ACS patients. And the last part is that these are all very small studies, so they're not actually powered to look at events such as stent thrombosis, whereas the DAPT study, which I'll show you, is. So let's go on to the other part of the argument. So what about long duration? What is the evidence? So just going back to those of you like myself who've got white hair in this room, some of you might remember the Charisma trial. And the Charisma trial essentially took patients that were at a high risk of atherothrombotic events and randomized them either to that were stable, and basically took these stable outpatients, randomized them to either aspirin alone and aspirin plus clopidogrel. And overall, this was actually a negative study. However, when they actually looked at the subgroup analysis of Charisma, several interesting things came up. Those patients that have atherothrombotic disease were definitely the ones that benefited from clopidogrel. But on top of that, patients that have had previous infarcts would be the other groups. So high atherosclerotic burden, history of previous infarcts, those were the 2 groups. And that has really led up to why we're doing all of these new studies. So the question really is, did Charisma fail because it didn't get the right population and it was too aggressive in terms of trying to get all patients, including those patients with just risk factors but no documented atherothrombotic disease? So the first study that came along was the DAPT study. DAPT study essentially included all patients that were primarily drug-eluting stents, and they randomized them to after 1 year. So all patients got treated for the 1 year. After the 1 year, if they've not had an event, they got randomized either to continue a thienopyridine plus aspirin or aspirin alone, treated up to 30 months. And then they did a second part, which I think is very important. At the 30-month mark, they actually stopped the P2Y12 agent and followed them for an additional 3 months. And the reason for that is that there's always been a hypothesis of a possible rebound effect, so that at the time that you stop, a couple of months afterwards, that's where people have events, and that's why they did this 3-month follow-up. Again, this was supposed to be a drug-eluting stent study, but they did have almost 3,000 that were bare metal stents as well. In terms of antiplatelet agents, they were all thienopyridine, so majority of them were clopidogrel or Plavix, but there were some patients that were Prasugrel, 35%. Most of these were drug-eluting stents. And here they only broke down the drug-eluting stent groups, and they consist of a combination of novel generations, so everolimus in green here, but there are older generations in terms of sirolimus and some paclitaxel stents as well here. So I won't go into the details here, but just to keep in mind, nearly 40% of these patients were actually acute coronary syndrome, so they did include stable coronary disease in this cohort. And in terms of the primary, co-primary efficacy endpoint, they looked at two things. They looked at stent thrombosis and they looked at the MACE. And when you look at stent thrombosis alone, clearly by having patients on a phenylpyridine at 30 months, that there was a reduction in outcomes compared to those patients on aspirin alone. And there's no convergence of the curve in the next 3 months, meaning that people were not having additional events when they were taken off the drug. In terms of the big things, again, stent thrombosis was significant as one of the co-primary outcomes. Overall MACE was also significant. Unfortunately, death was not significant, and numerically, death was actually the other way around. And we'll get back to that when we talk about the post-hoc analysis that they carried out in AHA this year. Myocardial infarctions, 2 important points here. Number one is that, remember, these are patients that are on dual antiplatelet up to a year and then randomized. What you see here is that in the first couple of months, clearly there's a quick divergence of the curve. So by having and continuing them on a P2Y12, they did better right away. And again, that is carried out to 30 months, and there's no convergence of the curves after that. However, anytime we have ischemic endpoints, we always have to balance that by bleeding. And not surprisingly, there was an increase in moderate and severe bleeding by having them on a P2Y12 agent versus aspirin alone. But in terms of more severe bleeding, that was not significant by itself. So the question is, does the drug matter? So I showed you evidence in terms of the DAPT study that had clopidogrel and Prasugrel. This is actually an interesting sub-study of the Trilogy study. So Trilogy was patients that were on Prasugrel treated medically, and they wanted to see whether there were any differences in those patients on Prasugrel versus clopidogrel. It was actually a negative study. But they did a landmark analysis, and anytime after that 1-year mark, interestingly, those curves started to diverge. Again, it's what we saw in Charisma. Is it because these patients, we know they've got atherothrombotic disease, that by treating them on a long-term basis, they actually have benefit from a more potent agent versus a less potent agent? So the other big study that came along was Pegasus. So Pegasus was looking at ticagrelor, randomized them to either placebo versus 60 milligrams BID or 90 milligrams BID. These were all patients that had had a previous infarct in the last 3 years, all were above the age of 50, and at least one of the risk factors, which I'll show you. And again, this was a long-term study that they carried out. So in terms of reminding, this is not generalizable to all patients. These were patients that were over 50 and had one of these, so greater than 65, diabetics, a second MI greater than a year ago, multivessel disease, or renal dysfunction. They all had to be able to tolerate aspirin. Looking at the primary outcome of this study, no difference between the 90 milligrams or the 60 milligrams in terms of the overall MACE, but clearly this did better than placebo. And those effects, again, carry out towards that 3-year mark, similar to the DAPT study. And when we look at potential subgroups, when we talk about components of that primary endpoints, what you see here is that death was 0.06, so not significant, unlike their previous study before, but definitely where you make the benefit is infarcts, and the surprising thing is actually stroke, and right now their company is actually doing a number of stroke-specific studies. This is the part in terms of subgroup analysis. There were concerns before in terms of whether there were differences by ethnicity, and this is not seen in this study, unlike their previous study. But one of the key points is that when you actually look at the MIs, those patients that had MIs more recently are the ones that benefited the most, whereas patients that had MIs later on were ones that didn't. And they actually had a separate analysis looking at 1 year. So those patients that were the first year after the infarcts at year 1 and got continued on it, those are the ones that actually benefited the most. In terms of bleeding, again, this is similar to what we saw before, is that there is an increase in terms of TIMI major bleeding and minor bleeding, But the reassuring thing is that in terms of the really bad fatal bleeding or intracranial bleeding, that these were not significant. Okay. Other adverse events, and these are something that we have to be cognizant of, because when we see patients in follow-up, we unfortunately see lots of these, that patients come back and complain of dyspnea. In the original Plato trial, that was 13%. Here, it's around 18%. By taking a lower dose, it lowers it a little bit to 15%. So definitely that's still a matter of concern in terms of especially now moving to treating a chronic scenario rather than someone after an ACS. And the summary really was that there was a benefit of ticagrelor to low-dose aspirin alone in patients that have had MI in terms of reducing the overall ischemic risk. Okay? But that the two doses had similar efficacy and bleeding, and the side effects potentially is less with the 60 milligram dose. So I think it really comes back to, in our minds, when we see that patient at 1 year, we have to be able to say, what is the bleeding risk in this patient? What is the thrombotic risk in this patient? And that's a very difficult question. I think we have to look at the patient demographics in terms of comorbidities, in terms of bleeding risk, whether the original presentation was coronary artery stable disease or an ACS, and also what type of stent they had. Was this a first generation versus a second generation stent? And the question is, can we apply this to practice? So when all of this data first came out, Joe Montelesco actually came up with this, and a number of people have voiced similar opinions, which is we look at patients at high bleeding risk. So prior bleeding, advanced age, pending surgeries, patients on triple therapy, people with lots of comorbidities, those are the ones who would shy away in terms of more than 12 months. But on the other hand, in those patients with extensive stenting, first-generation stents, diffuse disease, those are the ones where we would actually consider a prolonged approach. So the question is this scientifically proven? And this was actually presented at AHA this year. What they did was they actually have a separate department within their epidemiology group that specifically looked at effects models and did this very complicated analysis, which, again, the epi person in me finds very interesting. They actually did a number of separate logistic regression. They did one purely on bleeding risk and essentially arrived that the only thing that was consistent was age. Then they looked at things that were predictive of ischemic outcomes on a separate logistic regression and came out with this. And then did a third analysis, which was patients that had NACE, so bleeding and ischemic outcomes. But the interesting thing, when you look at the percentage of variation that's explained, when you take a NACE approach, so that things that were predisposing to both bleeding and ischemia, those ones actually drop out. Then they basically systematically looked at this and assigned a weighting on each of these, and then subsequently came up with the DAPT score. So the DAPT score basically looks at several things. With things like age, the more elderly you are, you actually get a negative score. But with things like diabetes, smoking, prior MI, prior PCI, those add scores. And the DAPT score can range anywhere from -2 to up to 9, I think. And basically come up with the score. What they then did was they did a whole bunch of analysis on a separate cohort from another study and came up with this, that if you had a DAPT score of greater than 2, those are the patients that would benefit in terms of having them on prolonged antiplatelet therapy, whereas those with a DAPT score of less than 2, those are the ones that did not benefit. And the hope is that this really might help people in terms of predicting who are the patients that's going to benefit, who are the ones that are going to not benefit. However, there is some corollary to that. First of all, this was based on a DAPT study, so this theoretically would only be applicable for patients that were originally on clopidogrel, which is what they did here, and we can't extrapolate that per se to ticagrelor. However, I think that intuitively it makes sense that the risk factors I showed you that were derived from the DAPT score was consistent between both of those studies I showed you. Again, reflective of our age nowadays, so you can actually go onto the DAPT site and they have their DAPT calculator, which is available. And just in the interest of time, I was going to do a demo, but you guys can all try this yourself. The calculator is very easy to use. When they did the interview immediately after Dr. Ye's presentation, the speaker actually says, this is very 1990s, is when you use a website. In 2015, it should be an app. So needless to say, the app is on its way and should be here very soon, but there's going to be a DAPT app. And I think on a clinical basis in the clinic, I think we should really be aware of those risk factors I showed you on the DAPT score and try and apply that at least on a mental basis, if not actually pulling out a DAPT calculator. So in summary, I think the current guidelines still suggest that ideally there should be at least 12 months of dual antiplatelet therapy for both after PCI and after acute coronary syndromes. Certainly, the smaller studies does suggest the possible safety of dual antiplatelet therapy for less than 6 months, but keeping in mind those were not to look at endpoints such as stent thrombosis. And in the 2 largest studies to date, there's definitely an increase in terms of, a decrease in terms of ischemic outcomes with prolonged dual antiplatelet, both of these up to 30 months, but all of this comes at the cost of bleeding. Okay, so I think the ideal approach is look at your patient, look at the bleeding history, look at the demographics, possibly apply the DAPT score. And I think the most important thing is we really need to sit down with the patient. So when I see a patient at 1 year right now, I sit down, I go through the risk benefits, and ultimately the patient should have a say in terms of where things go. Okay, thank you.